Welcome to the Texas Heart Institute educational programs featuring cardiology in the time of COVID-19 pandemic. The title of today's presentation is Cardiac, Cath Lab, and STEMI in the time of COVID-19.
So today we have with us Dr. Zvonimir Krejcir, who's an interventional cardiologist at the Texas Heart Institute and program director of peripheral vascular intervention at THI, as well as clinical professor of medicine at the Baylor College of Medicine. And George Eunice, who is an interventional cardiologist at THI and associate program director of our fellowship program, in addition to being the medical director of PCI and STEMI services at Baylor St. Luke's Medical Center. And my name's Emerson Perrin. I'm the medical director of the Heart Institute and the medical director of the catheterization laboratory at BSLMC.
Thank you, Dr. Perrin. What are the disruptive effects of COVID-19 pandemic on the healthcare services? We know that COVID-19 is a new pandemic with enormous impact on healthcare, on the hospitals, many specialties, intensive care units, staff, and equipment. And the cardiac cath lab is certainly not an exception to this particular problem. To improve safety of our patients and staff, we have to reorganize our patient flow. We have to reorganize procedural steps and implement new restrictive measures when and how we perform the procedures. If at all possible, these measures should be implemented before the worst of the major outbreak of this pandemic is happening in our community.
So as we focus this short program in this ever-changing world of COVID, we really want to focus on the cardiac catheterization laboratory and some very fundamental and important steps, and try to share some of the interactions and results from the interactions we've had at with our colleagues around the world and also in the Common Spirit program. So first of all, it seems logical to really want to perform these procedures safely only in a designated COVID-19 environment. And that means a dedicated COVID cath lab in the catheterization laboratory. In the case of THI, all the cath labs have a positive flow, and that is something that, as it turns out, seems to be an acceptable way to work. Of course, keeping in mind, the second point is that we really need to be extremely strict in using and implementing PPE for every single procedure. So what are the main things that we've done to prepare the catheterization laboratory in terms of the COVID situation? Well, first of all, we've gone, this is an ever-moving target, and we really have gone from doing some elective procedures and looking at guidelines that have come from SCI and from ACC and letters that have been put out, and gradually reducing the volume of the elective procedures to, we've gotten to a point where we really do not do elective procedures now and do what we call tier 2 and tier 1 cases, which are emergent or urgent type cases that the patient will impact the patient directly if they're not done. Many times cardiology is an interesting specialty in that it's quite fluid. It's difficult to predict certain outcomes. So we do the best that we can with common clinical sense, using our judgment many times. There aren't always cookbook answers to these questions. The other things then that we want to do is also be mindful of the staffing of the cath lab. Who are the interventionalists that are going to be involved, and with the primary idea of reducing the staff that are exposed. And there's 3 cardinal things that we always want to keep in mind. Number 1, exposure of the patients. Number 2, exposure of the staff. And number 3, preservation of our resources. Dr. Eunice has done a really fantastic job in putting together what I think are some really key questions that I think we can explore, answer, and will sort of help us encompass our approach to COVID patients with acute, urgent, or emergent cardiovascular issues that need to be addressed in the cardiac catheterization laboratory. So the first question is this, and I'll let George answer it, is do we assume that all patients have COVID-19 until proven otherwise?
Thank you, Emerson. Thank you, Zvonko. That is a very difficult question, and certainly a lot of protocols that have been developed have looked at, well, you have patients that are high risk for COVID positivity. They may have a fever and cough, and those cases are easy. But we are knowing more and more that there are patients who can still disseminate the virus who have scant symptoms, if any. And so in an emergent situation where you're worried about a STEMI, the most prudent thing is probably to assume that the patient is COVID positive, take all the necessary precautions for yourself and for your staff, because aside from the human aspects of getting sick, if the more people are exposed, the more people get put on quarantine, and then you don't have enough staff to take care of other patients that may come through in the coming weeks. So I think that's the most prudent thing to do.
And I think an important point in that is that testing is critical, and the availability and the rapidity of testing as it becomes available will have a major impact as we can quickly identify these patients versus now when that kind of delays things. And we'll talk about the order of balloon times.
We sure need that badly. We need rapid tests very, very soon.
Second question, we don't have a negative pressure cath lab. So what do we do with that, George?
Well, as it turns out, very few, if any, centers do have negative pressure cath labs because, like all operating suites, they're to be positive pressure environments, not to draw in microbes in from the outside. But with the COVID patient, we don't want to be blowing any aerosolized particles outward. But unfortunately, turning a positive pressure room into a negative pressure room isn't just a flip of the switch thing. If you're lucky enough to have a window, apparently this may be an option. I mean, I'm not an engineer, but this is what I've heard. The next best thing is to continue in your positive pressure environment, as we mentioned before, but maybe with the installation of a HEPA filter or other relevant filters to sort of do the best you can to filter out any microbes from being transmitted.
Yes, we were recently on a webinar with international and national centers, and actually it was interesting to see one of our colleagues in Chicago had transformed one of their rooms to have a HEPA filter in it. I thought that was very interesting.
Mm-hmm.
Okay, let's go to the next question. So should Cath Lab staff wear full PPE for all cases?
I think that is certainly the most prudent thing to do in the spirit of protecting everybody as much as possible. It does probably add time and some burden to the case for every technician, who's or scrub tech or every nurse to be in full PPE, because that's not what we normally do. But I think that is the most prudent course.
Okay, and now let's get into a little bit more. When we're talking about these urgent and emergent cases, we're really going to start talking a little bit about STEMI specifically, because that's what we're dealing with. And just as an aside, I think it was interesting that many centers around the world and in the country have noticed an actual decrease in STEMI volume. And that's maybe something that changes or that's temporary, or we really don't know the explanation for. Maybe some of these patients are staying at home and we'll be seeing them later. But nonetheless, we haven't gotten the idea that the cath labs are being inundated with these acute cases, although there's some peculiarities that we need to talk about. So first of all, should stable or low risk patients be considered for thrombolysis? And if so, where do you do the thrombolysis, and then how do you follow up on that?
Yeah, very complex question. But I think most centers are definitely considering use of thrombolysis, even in PCI-capable centers, in particular patients who may be low risk. The use of thrombolytics up front, if successful, may obviate the need to go to the cath lab at any point. And especially, if you have a patient who is highly suspicious for COVID, if you can keep that patient out of the cath lab, that may be a great thing to do if there's not much of a trade-off in terms of patient outcomes. So, what is a low-risk STEMI patient? The recent SKY guidance sort of outlines several features that may be relevant for that, but patients who are maybe hemodynamically stable inferior MI, lateral MI, but anybody who's has hemodynamic instability would not really fit in that category. So I think thrombolysis should absolutely be considered because of you may protect your staff and you may conserve people. Now, as to where it occurs, that's a bit more complicated because if you're assuming these patients have come in through the ED, then probably it makes most sense for the patient to get thrombolytics in the ED. Most EDs have some comfort with this concept from taking care of stroke patients. And so hopefully, modifying existing protocols to allow thrombolysis to occur for STEMI patients would be sort of a lateral move in that regard. There may be some centers, however, where they don't feel comfortable doing that and want the patient to be moved to an ICU. But these things are probably institutionally based and need to be carefully thought out as part of your protocol. And then the question becomes, well, what happens? If the thrombolysis is successful and the patient's doing fine, then you have some time to decide if you're going to take the patient to the lab. And during that time, you can learn whether or not the patient is COVID positive. As it stands now, you're lucky if your center can get you results in a day. And so if the patient has successful thrombolysis, you monitor them in the COVID unit, you wait for the COVID results to come back, and then you know what's going on with the patient, and you can decide, do we need to risk stratify this patient further and before taking them to the lab, or do we just take them to the lab, or what do we do next? Now, if they're COVID positive, it becomes more complicated because there's you may say, gosh, the sooner we can get this patient out of the hospital, the less risk there is to everybody else. And follow up the coronary disease at a later time frame. These are complex questions that are going to, of course, be very individualized, but they're very important.
And I don't want to give our listeners also the idea, and I don't think that you've done this, but just to kind of reinforce the point, is that what was your impression in that? How are most of the centers around the world and here in the U.S. Dealing with STEMIs? Did you get the feeling that there's just this shift to thrombolysis, or is there really continued mainly direct PCI going on?
Yeah, well, my impression, even coming from the gentleman that we heard from in Italy, was that primary PCI was still the mainstay. But I think a lot of people are looking at it as, well, as we lose, if the availability of PPE continues to go down and even the availability of healthy doctors and staff goes down, we may need to really look at thrombolytics in more patients. But I think currently, outside of some papers that came from China, everybody else still seems to be favoring in practical work, using primary PCI most of the time. Okay,
and then that takes us to an interesting question, which relates to getting a clue. Some of these patients with COVID, they have myopericardial involvement, and they may have really myocarditis with ST changes that look like a STEMI. And then what can you do to identify these patients? So should echo be used more often prior to deciding to go to the Cath Lab? And then how do you make that logistically happen? How do you operationalize that?
Right. So I think this is a really important and useful point. And even before that, the history is even more important than ever. All SE elevations are not STEMIs. You may have EKG changes in a patient who has a febrile illness, and that's a very different situation than an EKG change in someone with acute onset of chest pain. But when you have a situation where you're not certain what's going on, but you do have ST changes, a real great way to help to understand that is to do a quick echo. And if you have a echo that shows wall motion abnormalities in the same distribution where you would expect them to be based on the EKG, then that supports that this may actually be a true STEMI. Whereas if you see a perfectly normal appearing LV, or you see sort of global wall motion, global mild hypokinesis in someone with like a inferior ST changes where it doesn't really add up, then that might temper your enthusiasm to pursue it as a STEMI and take the patient to the Cath Lab, or certainly to give thrombolytics. So I think echo can be a really useful adjunct. And as to who would perform the echo, this is going to be very institutionally dependent. Academic centers like ours are fortunate to have capable fellows who carry around a portable echo machine and can come look at the patient ultrasound by ultrasound real quick and tell us what's going on. Other centers may have to have protocols involving either in-house staff or emergency room doctors who have sufficient training to be able to really draw those conclusions.
Okay, and so I'm going to skip to question number 7 before I go to number 6 because it's kind of related. Let's talk about CTA a little bit. How does that fit in? Can it help? What are your thoughts on that?
Well, I think it's a very interesting idea in cases where you don't really know what's going on. If you're not sure if it's a STEMI or not, even after you maybe done a quick look echo, theoretically doing a CTA might be very beneficial to at least get a sense of certainly the proximal coronaries. Let's say the heart rate has to be low enough to get a really good study, but in most patients you can at least see the very proximal coronaries and see what's going on. But the problem with doing a CTAs is, of course, then you expose the CAT scan staff and the CAT scanner itself to potential, exposure to the virus, and that needs to have a big clean afterwards. And another is availability. I don't think most centers can do CTAs, good coronary CTA 24/7. In most centers, and certainly at least in our center, the best trained staff for doing that are only available during daytime hours. So it becomes a little more complicated. I think it's something that's probably evolving and may have its place, but it's a little bit hard to implement.
So it really looks like echo's sort of the practical, quick way to see if a STEMI is really a STEMI, if you're in doubt about that. Huh?
I think it's helpful, yeah.
So now let's shift gears a little bit and think about, let's say we're taking a patient. We've decided he has a STEMI. We're taking him to the Cath lab. What about intubating that patient? What's our threshold for doing that, and what's the consensus on that?
So there's been a lot of discussion about perhaps having a lower threshold to intubate these patients prior to taking them to the Cath lab. I know in our center, intubations of suspected COVID patients or emergent patients are only being done by anesthesia these days, as opposed to by ER staff or pulmonary or other people, in order to make sure that it's done in such a fashion as to minimize risk of aerosolized particles. And if you have a patient with a STEMI, this is a patient who is certainly at risk of decompensating in the next 10 minutes, 30 minutes, an hour, and during the procedure. And if that patient crashes in the Cath lab, you risk exposing the entire Cath lab staff to aerosolized particles. Whereas if you are more proactive and intubate people on the front end prior to bringing them up there, now the respiratory circuit is closed already, and you're not going to have aerosolization of particles. And incidentally, if you have done a coronary CTA before taking this patient to the Cath lab, you'll also see the lung windows, and you might have a clue as to what's going on if you start to see ground glass opacities on those patients, which frequently look much worse on CAT scan than they do on X-ray or even clinically. You might also have a lower threshold to intubate that patient prior to bringing him in the Cath lab for the safety of yourself and your staff.
Okay, so where do we want to preferentially intubate these patients? Do we do it in the emergency room? Do we do it in the ICU?
Well, I think these patients who are STEMIs, they're in the ER, and before they go to the Cath lab, I would do it in the ER in most cases. Okay,
so bringing up door to balloon time, this whole COVID crisis puts it a little bit in perspective. We're always so worried about NCDR metrics and this and that. Well, right now we're worrying about saving people's lives, and it doesn't really matter the door to balloon time in terms of the metrics, but it does matter in terms of patient outcomes, right? And if it takes an hour to let a room clean up and the particles settle down, and then you have to do a terminal clean, depending on your volume and how things go, there are going to be delays in the system. And so what is this all going to do to our door to balloon time, and it's sort of in that perspective? And how do we think about thrombolysis again? So I'm just kind of bringing up that point because it's important.
Yeah, I agree with your sentiments. We spend so much time thinking and talking about metrics in normal times, and now it just seems so relatively silly to be talking about these other esoteric numbers when we're trying to just deliver care at this point. But it's, of course, it's a relevant point, not only with the cleaning, but these ancillary tests we're talking about, like a CAT scan or an echo, or just getting the PPE for the whole staff that takes additional time. These are delays we're not accustomed to. And so, if you can't get your door to balloon time in acceptable manners anymore, then, if we're starting to treat patients 2 hours after they present, well, maybe we would have been better off giving them thrombolysis if it was a stable patient, because they would have received a chance of reperfusion right away. And so that's a very difficult question to tease out, and I think it's going to be answered by each institution as they go forward taking care of these patients and see how much delay they are seeing prior to getting these patients into the cath lab. And if there appears to be a lot of delay, then, again, the idea of giving thrombolytics in certain cases might be considered better, just because there's a chance of reperfusion faster.
Yeah, I think there's a lot of things that we don't know.
Yeah.
Our answer to some of these things may change over the next, even in a week. And as we get a more practical sense of these things, maybe we'll even go in a different direction. So the final question I want to ask you is shifting gears from STEMI to NSTEMI. So what is the general feeling regarding treatment of NSTEMI?
Well, in the spirit of everything that's going on and protecting staff and conserving PPE, I think the general mood on this is to be more conservative. I think we have generally had a pretty aggressive strategy towards these non-STEMI patients, but the truth is many of them can be treated medically for their NSTEMI and then only undergo catheterization if they have certain high-risk features. And so I think certainly a slow approach is best in these patients right now. And of course, if there's any instability, that's an easy one. But if they're very stable, there may not be any good reason to take that patient to the cath lab right now. You could send them home, see how things go, and then reconsider.
And I agree. And that's a message that I heard very clearly from our colleagues from around the world and here in the US, is really the shift. And I think this varies regionally as well, but the shift in how we manage these patients, and really only thinking about an invasive strategy in people with ongoing ischemia who might be in trouble.
Let me ask you a couple of questions that are also very pertinent and related to this topic. And both of you can answer them because I think they're important. One is, should we dedicate COVID-specific cath lab for those COVID positive patients? And we at our institution have over 100 interventional cardiologists. Should we allow all of them to perform procedures, to be exposed to a potential COVID-19 infection? Or should we decide that we'll have a dedicated team that will be doing those procedures to avoid excessive use of PPEs and also exposure to many of our interventionalists? So maybe each of you can address this question.
Well, I'll just start with the personnel issue. Again, the practice patterns really vary around the country. At Texas Heart, we still have private practice groups, and one of the interesting things that I've seen is some of the groups dividing their groups that have let's say 6 doctors, dividing them into the interventionalists into teams where some of them are off or not in the hospital for a period of time, and they really alternate when they come in. But I think it's really going to vary a lot with the practice patterns locally in different places.
So the reason that I was asking this question, because in other countries where there is socialist medicine, they're basically limiting the number of interventionalists that are doing the procedures. That is true in a lot of European countries. And if we get a severe increase in number of the cases, we might have to consider something of that kind also here in the United States. George, any other comments related to this?
No, I think that's as Emerson said, I think it's something that's going to be really institution dependent. I've heard of different proposals that are from different countries, different institutions here in the U.S. And some are doing just what Emerson was talking about amongst themselves, is staggering staffing of the Cath Lab from a physician standpoint. There was also a discussion on our call last night about whether physicians over 60 should be excused from doing cases for the time being. And of course, it's going to depend on, well, how many people does that leave you? Does that leave you only one guy, or do you have a bunch of young guys? So there's a lot of things to think about in this regard and trying to keep everybody safe.
Well, thank you very much. If you don't have any other questions, I would like to thank to you, Emerson, and to George for your very valuable contribution to this Texas Heart Institute program on the cardiac cath lab and STEMI in the era of COVID-19. Thank you very much for your participation. It's a pleasure to work with you on our educational programs. For those of you that have tuned in to this program, please join us for our next program on cardiology in the time of COVID-19. Stay healthy and treat your